Good evening to everyone. I welcome all the vets, small animal practitioners on behalf of Indian Association for Veterinary Dermatology and also our knowledge partner INTAS Animal Health for this wonderful webinar. We have been facing a lot of issues with the endocrine diseases, particularly in dermatological issue. We have got more commonly hypothyroidism and hyperadenocortism as a major one. And in that hypothyroidism, we have got a lot of issues with the genetical background and also with the breed involvement. So we want to know more about it. If we come across any breed which is having tendency to go for hypothyroidism, we can closely watch it and then tell the owner so that they will be having an idea to prevent the disease or to maintain the disease. How if you are going to lose or how you are going to manage the disease with a easier way so that we'll be in a position to give a good quality life for them. Likewise, if we take hyperadenocortism, majority of the cases we come across with the iatrogenic, say either owner themselves are treating with the topical ointments or even orals. Sometimes they will think only by injection or tablet it will come as iatrogenic, but generally we come across a lot of cases with the external application itself. So that we have to concentrate more on it. And then apart from the iatrogenic, we have got this pituitary hyperplasia, pituitary tumor or adrenal tumor. All these things also can lead to this hyperadenocortism. So we have got a lot of issues with these two diseases, major diseases in our practice. So we wanted to have more and more knowledge about it, easy way to approach it, easy way to handle it, and how to go about it. All these things we can find in a simple way with today's webinar. See, we are here with our expert, Dr. Satish Kumar, who is a professor and university head of Hyderabad Veterinary College Clinical Medicine Department. So the veterinary clinical medicine branch, he has done a lot of work in dermatology as well as cardiology. So he'll be giving a very good points for practice for as a take-home message, I think. So you can all like you, I am also very curious to watch his talk. Thank you. I welcome Dr. Satish also. I request our Dr. Nitin to introduce our guest speaker. Please, sir.
As rightly said by Dr. Nagaraj, we all are waiting for Dr. Satish to start. But still, as a requirement of the webinar and to make the ball rolling, let me introduce Dr. K. Satish Kumar, an immediate senior of mine, 1 year senior to me. We are both graduates from Hyderabad, and of course, he has gone up to the PhD level, and he is now practicing clinician and a university professional. So he specializes in canine internal medicine primarily. He has worked on non-invasive diagnostic techniques, ECG, ultrasound, and echo. These are his key areas of work. He has also authored a book in Telugu, which is currently being followed by in Telangana and Andhra for all the 7 animal husbandry polyclinic colleges. So he has a lot of work, and number of works are for the first time in the country. Like he has worked on cardio myopathy for the first report in India. He has worked on diagnostic of anesthesia for the first time in India. He has worked on hypothyroidism, ultrasonic evaluation of thyroid glands for the first time in India. He has also made a number of attempts, especially in canine atopic dermatitis for the first time. I know him as a good clinician, a good university vet. He has been honored with Dr. P.K. Das Gold Medal, Best Teacher Award from his university, Dr. D.C. Blood Award from ISVM, INTAS Young Scientist Award in 2012, Appreciation Award from ISVM, number of awards from various journals because he has had good amount of publications. His students, three of them are also INTAS Young Scientist Award winner, and he has done a lot to contribute to the profession of veterinary medicine. I no longer disturb his presence and request him to come down on the stage and deliberate on the topic canine endocrine dermatosis. Over to Dr. Satish.
So nice to have Dr. Nitin, a friend of me, uh, here on this platform, and also I thank Dr. Nagaraj sir, Professor of Medicine from Tanvas, and leading active participant in the Association of Veterinary Dermatology. So I thank you, sir, for giving me this opportunity and being a part of AVD and taking a webinar on this most relevant topic. Thank you so much. And I thank the knowledge partner, INTAS Pharmaceuticals, personally Dr. Nitin Bhatia, and also Dr. Amanjot Singh, arranging this talk and coordinating the work. So I also thank all the participants who are waiting here to be a part of this. So without wasting much time, I just would like to move forward. And the topic that I was assigned to deal with on this evening is regarding this endocrine dermatosis, with particular reference to hypothyroidism. As Dr. Nagaraj sir rightly pointed out, this endocrine dermatosis is one of the, I can say, neglected area rather, though otherwise I can say it is a bit confused and sometimes most complicated area to understand very clearly. And not only that, in the present scenario, the cases or the clinical cases that every day every practitioner is being experiencing and being undergoing a lot of stress in dealing with these dermatosis. So this is the reason why I was assigned to talk about this endocrine dermatosis and with particular reference to the hypothyroidism. So just moving on to the talk on from here onwards, maybe for 45 minutes, we'll be just discussing about various endocrine dermatosis, as Dr. Nagaraj introduced a few topics like hyperechinocorticism, hypothyroidism, and of course there are one or two other issues also which are actually more closely associated with endocrine issues and particularly which causes dermatosis, and in detail about these. So we just move on with the topic entitled endocrine dermatosis, and with particular reference to hypothyroidism. As I was talking to you, well, why this topic was chosen, and I was able to say that if you look at the present scenario, there is a lot of change in the lifestyle, both in human and also in animal sector, that is the pets, the companion animals. Probably the change in the lifestyle might actually be causing some issues as far as the different issues are concerned. Maybe any other issue we can take, but everything what is actually happening in human life in the present scenario is just somehow directly or indirectly connected to an endocrine mechanism. Probably if you say very specifically, it is a neuroendocrine kind of mechanism. So say for example, the stress factors nowadays, maybe because of the busy life or due to the job chart, so many young and youth actually are being facing a lot of endocrine issues. To say for example, infertility is one of the emerging issue in the present generation, and actually I can say it is lot many endocrine institutes or fertility centers are being coming up. So, and you can take the most common issue with the human population, the baldness. So previously it used to be in people who are actually more than 50 or 60, but now the baldness has become so common in the present youth, maybe in college students even. So all these things are actually directly or indirectly correlated to the endocrine disturbances or hormonal imbalance that is being taken place in humans, just because of either change in their food habits or maybe change in their living style, or so many things are the stress factors, I can say. So the same thing is also being practiced in companion animals, in the pet animals. So we can see lot many changes and lot many diseases which are being actually being faced by the practitioner in their day-to-day life, and many of them, I can even say that previously pets used to have a very good healthy life and a lot of space to walk around, to have a good exercise, but nowadays I can say they are restricted to indoors, and maybe lack of physical exercise or lack of vitamin D or any other things, or many more things rather, ultimately making them to obese. And diabetes mellitus is one of the endocrine disorder which is actually being raised both in humans and also in pet animals. So if we talk about in this way, there is a lot of importance for the endocrine component of uh, the science or the medical field, which is actually rising up and which needs to attend. And I think this is the right time for all of us to um, talk about and to refresh our knowledge that is actually present and related to endocrine diseases that are particularly causing dermatoses, and maybe in specifically about the hypothyroidism. So I strongly believe this topic will give a good information, will share a good information for the learners, and also will cheer up and freshen up the knowledge of the learners who are the participants here. So quickly, if we move forward, so the literature and the documented references also says that about 75% of the cases that every day the practitioner experiences includes the skin problems, and almost 9 to 10% of them are endocrine related skin. And though there are so many dermatopathies, so many types of dermatopathies, endocrine dermatopathy is also one of the major important endocrine dermatopathy that should be attended every day by the practitioner in their routine life. And in one study, hypothyroidism was noticed in almost 33% of the cases being attended by an author or a scientist. So that showing the importance or the impact or the role of hypothyroid diseases as a part of endocrine disorders. So keeping this importance in mind, we would today discuss about endocrinopathies or endocrine dermatoses, particularly hypothyroidism. So before going in detail about the actual component, let's have a quick look on the various components of the skin. So the skin of the dog composed of three main layers. Okay, and undoubtedly it is the largest organ and almost weighing about a quarter of its body weight. And the major role of the skin is it acts as a protective barrier, and of course it also acts as a thermoregulatory mechanism in case of dogs specifically. So this is composed of three main layers. In the major layers, the first one is the epidermis, which is an outer layer. So epidermis still again consists of multiple layers, or the multiple types of cells. So keratinocytes, melanocytes, Langerhans cells, and the Merkel cells. So the keratinocytes are nothing but the layer of outer layer of the epidermis, which actually they renew frequently and repeatedly, and in a systematic way through a process called as keratinization. So through this keratinization, the cells, the cells they generate at the bottom layer of the epidermis, and then they come upwards and forms a top layer, which is actually nothing but the dead cell layer. And this dead cell layer will be depriving of, or will be falling off frequently and leaving the fresh keratin cells. Bringing up the fresh keratin cells. So this keratin layer actually prevents the intoxicants, the inflow of intoxicants, or prevent the inflow of any other pathogens through the skin, and also it protects or prevents the loss of fluids from the skin. So this keratin layer actually protects the skin and the protective layer of the epidermis, I can say. And this keratin layer is being influenced by nutrition or the hormones. So whenever there is a malnutrition or when there is hormonal imbalance, the keratinization process is either speeded up or obstructed, so leaving or causing abnormal keratin layer and thereby prevent or thereby uh, causing a hindrance for the protective mechanism actually the keratin layer is going to cause. So the next to that is the melanocyte. The melanocytes, they are present at the base of the epidermis layer, and they're also present at the outer root sheet of the hair. So everybody knows that the melanocytes, they secrete a pigment called the melanin pigment, and this melanin pigment actually prevents the skin from harmful ultraviolet rays of the sun. And again, these melanocytes are being influenced or by the ultraviolet rays, or including it also being these melanocytes are being influenced by the nutrition and also the hormones. So when there is a hormonal imbalance, the melanocyte production or secretion increases, and thereby causing pigmentation of the skin. And the next type of cells that are present in the epidermis is Langerhans cells. These cells are involved in immunity of the skin. These cells, they actually play a role in protecting the immune mechanism for the skin, and actually these cells play a role whenever the skin is being influenced by any pathogens, external pathogens. So any sort of inflammatory reaction that is being occurring in the skin due to any external pathogens or any other allergens in the form of rashes, etc., is nothing but the action or the result of these Langerhans cells. And lastly, the epidermis also consists of the Merkel cells. These Merkel cells has got a specialized sensory action. So these cells are involved with the skin's sense of touch. So this is how the epidermis is involved and is composed of and its functions. And next, the dermis. Dermis is nothing but the layer that is present below the epidermis. And this is composed of the blood vessels, nerve functions, and the nerves distribution, and also the follicle, hair follicle. It provides nutrition for the epidermis layer and the cells that is present in the epidermis, and it also provides nutrition for the hair follicles. And lastly, the lowermost layer is the subcutaneous layer, also called as the subcutis, which is made up of the muscle, subcutaneous muscles, and the fatty tissues. So apart from these, the skin also consists of certain appendages like the hair. It consists of the claws, and so these things are present in the skin, and the hair, claws, etc., and the nails. So these things grow from the dermis, and then they'll be exposed out, which has got specialized functions for them. So when we talk about the hair or the hair follicle of the canine, this canine hair follicle or the hair has got a special characteristic feature. So it's not a single hair that is present, or a single hair follicle that is present like human, and it's not a kind of the life cycle of the hair or the hair follicle is something different in case of canine when compared to that to the humans. So these things in detail will be discussed in the next few slides. So yes, coming to the hormonal imbalance, yes, these hormonal imbalance that may be either low hormones or excess hormones or improper metabolism of hormones or improper functions of the hormones. Actually, whatever may be the reason, the hormonal imbalance may are going to cause alterations in three major functions of the skin. One is about the genesis of the follicles, and the production and the processing of the melanin pigmentation or the pigment, and the maintenance of the epidermal layer. So this alters the folliculogenesis, pigmentation process, and epidermopoiesis. So whenever there is a hormonal imbalance, these are the three important components which are being affected, resulting in abnormalities of folliculogenesis, maybe causing in folliculitis or even alopecia, and abnormal pigmentation that happens on the skin, and also abnormalities of the epidermal layers that are present on the skin. So put together, so whenever there is a hormonal imbalance, the affected patient exhibits the manifestations that are actually and primarily related to the cutaneous manifestations. such as discussed, such as alopecia, hyperpigmentation, and failure to regrowth of hairs, etc., and sometimes lesions on the skin also. So the most important point for every one of us to remember here is alopecia that is present in endocrine dermatopathy. But this alopecia is a unique type of alopecia, which is a non-inflammatory and non-pruritic kind of alopecia. So usually there won't be any itching sensation in the animal, and the hair loss will just be going off, and the animal and the client will be just seeing that there is just only loss of hair without any pruritus. But sometimes when this continues for some time of period, probably there could be a secondary bacterial invasion. So when there is a secondary bacterial invasion, there is possibility of pruritus. So otherwise, till then, hormonal alopecia is a non-pruritic and non-inflammatory kind of alopecia. So to discuss about the various endocrine dermatoses, we have three important conditions. One is hypothyroidism, no doubt about it. And the second one is hyperechinocorticism, as introduced by our Dr. Nagaraj sir. And apart from these two, I just want also like to talk something and to share something about hypergonadal hormones associated endocrine dermatoses. So these are the three important kind of endocrine dermatoses which we'll be discussing today. To start with, we discuss about hyperestrogenism and hyperandrogenism. So these are the two important hormones, abnormalities. They're nothing but the sex hormone abnormalities that happens in adult mature dogs, both males and females, and thereby it is going to cause some dermatological issues. So excess sex hormones that can be either estrogen hormone or maybe due to excess of testosterone, and which is actually maybe associated with neoplasia of the tumors associated with the ovaries, tumors associated with the testicles, so thereby causing excess secretion of estrogen and excess secretion of testosterone, causing dermatoses. So if we keenly observe the site of the predilection of the lesions, so the lesions or the alopecia patches, they are restricted for the perineum region, the ventrum, thighs, and the pericervical region in case of dogs affected with sex hormone related endocrine dermatopathies. And truly speaking, the flank region is most commonly affected, and the alopecia that is noticed at the flank is considered as the first or sometimes as the only sign that is noticed in these kind of dogs. And no doubt there can also be pigmentation, hyperpigmentation, and the leftover hair may sometimes remain as soft, or sometimes they become dry and brittle kind of dry hair fibers, which indicates gonadal hormone abnormality associated dermatosis. This is how it looks like. The lesions, they are initially restricted to the perineal region or the thigh region, and sometimes it spreads throughout the body with hyperpigmentation and melanosis here. And this dog, actually what we are seeing here is having cystic follicles or the ovarian follicles, which on surgical removal they notice that this is what actually causing these lesions on this dog. So, and sometimes, unusually, sometimes this is very much important for us to differentiate from other endocrine associated dermatopathies. There will be urinary incontinence, which is also noticed in estrogen and testosterone responsive conditions. Okay, so this is also one important manifestation that is to be considered by delinking the other, differentiating the endocrine associated dermatopathy. So among these, we have few different types. The first one, what we can say, is estrogen responsive dermatosis, which is commonly seen in female dogs, intact dogs. In ovariohysterectomy cases. This is related to the deficiency of estrogen hormones, particularly the deficiency of estradiol. And we have another case which is commonly noticed in intact female dogs, and that is hyperestrogenism, and this is related to the cystic ovaries or the tumors that are present in ovaries, or sometimes due to any hormonal therapy or estrogen hormone therapy which has been given for a longer time or an overdose, so which subsequently will develop to a hyperestrogenism. And the third one is hyperestrogenism in male dogs. This is very much important. I just want to, so this is in case of male dogs. So this is hyperestrogenism in male dogs with testicular tumors. So here also estrogen is excessively produced, and it is mostly noticed in cryptorchid cases. It is very commonly noticed in cryptorchids, or sometimes it may be with normal testicles that are present in testicle cases also, but mostly concerned with the sertoli cell tumors or seminomas, or sometimes interstitial cell tumors. And the next one is hyperthyroidism. This is associated with testicular tumors, that is in case of male dogs having normal testicles, and here the testicle tumors, they are having interstitial cell tumors, and these interstitial cell tumors that are present in male intact dogs will have excessive amount of secretion of male hormone. So whatever may be the case, whether it is an estrogen related issue or whether it is on testosterone related issue, every dog will have the same kind of manifestations what we have experienced previously. So then coming to the next condition, that is the Cushing's disease. Yes, this is the second important disease that actually concerned with endocrine associated dermatopathies, and this is a very important and a crucial disease that needs to be differentiated from the most important hypothyroidism, because most of the conditions, they look more or less similar, and it is very much important to differentiate and delineate both the diseases very thoroughly. So this is a disease that is very commonly noticed in adult dogs, and this primarily related to tumors in the pituitary glands. So we can say the Cushing disease is, it refers to any kind of disease that is actually causing hyperechinocorticism, that is excess production of the cortisol that may be either produced because of the complaints, the conditions in the adrenal glands, or may be produced because of the controlling gland, not actually the controlling gland, that is the pituitary. So this is what actually this image will explain us clearly about the Cushing's and the glands. The two glands that are involved in the Cushing syndrome is the pituitary gland here, and also the adrenal gland that is present on the kidney. So this Cushing's disease can be of two types. It can be a pituitary dependent Cushing syndrome or the disease, or it can be an adrenal dependent Cushing syndrome or the disease. So in pituitary dependent Cushing disease, the pituitary tumors or some sort of disease that in the pituitary gland releases excess of produces too much of ACTH, adrenocorticotropic hormone, which goes and stimulates the adrenal gland to release cortisol. So this is why it is called as a pituitary dependent Cushing's disease. And whereas the second type, this is called as an pituitary independent Cushing's disease, or also called as an adrenal dependent Cushing's disease, where the primary pathology lies with the adrenal gland. There can be tumors of the neoplasia of the adrenal gland, which actually causes for excess secretion and production of the cortisol. So whatever may be the reason, whether it is the pituitary dependent or pituitary independent, ultimately what is actually happening is excess production of the secretion of the cortisol, which is causing the Cushing's disease. So the same thing we can put it in a different way. It can be either pituitary dependent or also called as an ACTH dependent, because in pituitary tumor, the ACTH is released more fiercely, and this ACTH causes the adrenal gland to release more amount of cortisol. So this is what it is called as either pituitary dependent Cushing's disease or ACTH dependent Cushing's disease. The most of the cases, most of the dogs, almost about I can say 90 to 95 cases, 92% of cases of Cushing's disease are ACTH dependent or pituitary dependent. And whereas the second one, a meager portion of Cushing's disease is pituitary independent or ACTH independent, where there are adenomas or carcinomas that are present in the adrenal gland. So in either of these two cases, or in both the cases, the adrenal gland is activated more and will release or secrete cortisol hormone, and this is what actually causing so many causes or so many manifestations. If you look at the clinical signs of Cushing's disease, this is again the same what we have seen with gonadal hormone associated dermatosis. It's the same. The pigmentation you can see alopecia, and these are all the things which are actually lies common. But if we clearly differentiate this, there is a clear-cut differentiation. We have a patient with Cushing's disease with pendulous abdomen. This is a pot-bellied pendulous abdomen, looks like an ascites, but actually speaking, it can't be an ascites, it is a pendulous abdomen, which is very a predominant feature that should be noticed in case of Cushing's disease, apart from not just the pendulous abdomen, apart from alopecia and also hyperpigmentation. And the alopecia is also significantly noticed in specific portions, maybe on the ventral aspects of the trunk, and it is noticed, except I can say it is sometimes maybe noticed throughout the body except head and neck. So alopecia may be on the abdomen or the ventrum or the thighs, except the head and neck with pot-bellied or distended abdomen and hyperpigmentation. So these are some of the features of the dermatological manifestations noticed in case of Cushing's affected patient. So there can also be hyperpigmentation as noticed, as told here. Though it is not a dermatological complaint, the most important manifestation which is actually related and present in case of Cushing's disease is polyuria and polydipsia. So this is always a confusing kind of disease. That's the reason why I told you at the beginning of the talk. So endocrinopathies or endocrine associated dermatopathies are most of the times a confusing kind of will have a confusing kind of manifestations which are not specific for any disease, like polyuria, polydipsia. When we talk about polyuria, polydipsia, we think about diabetes mellitus, but this is a predominant manifestation we notice in case of Cushing's disease, but in addition to the dermatological lesions. So without dermatological lesions, probably polydipsia, polyuria, maybe we can say diabetes. But if the skin disorders, alopecia, pigmentation, pot-bellied appearance or distended abdomen, and hyperpigmentation, polyuria, polydipsia, probably it could be Cushing's disease. And there is also another important finding that we notice with the skin abnormalities, the skin manifestations of Cushing's disease is calcinosis cutis. There is mineralization. The mineral deposits are noticed on the subcutaneous spaces of the skin, which gives a white kind of flaky, tough kind of mineral crystal kind of lesions on the skin that may be present on the trunk, or may be present on the back, or may be present on the limbs and somewhere on the forehead. So they are also again a specific manifestation in addition to alopecia, pigmentation, polyuria, polydipsia, and pot-belly appearance. So these are the striking manifestations we can expect in Cushing's patient. So this is what I was talking about, the calcinosis and the cutis that is present with calcium deposit lesions on the skin, so which looks like mineral deposits on the skin. Okay, and interestingly, we can also notice on the distended abdomen where there is engorged vasculature. The veins are engorged and predominantly noticed on the abdomen, and this is just because of thinning of the skin. So thinning of the skin is also one of the important pathophysiological mechanism that happens because of excess amount of cortisols. There is gluconeogenesis and subcutaneous fat will be deprived of, will be metabolized, and leaving the skin very thin, tender. So that's the reason why, because there is no subcutaneous fat, the blood vessels are predominantly noticed when the skin becomes thin and very much tender appearance. So this is in a single picture. I would like to present the manifestations associated with the Cushing syndrome. So you can see this dash out here. Look at the shape of the abdomen, which is pendulous, almost touching the ground, and these are the lesions, the calcinosis cutis here, and there is deprivation of muscles here. So this is a typical feature in the posture or the appearance of Cushing's patient that is present when it is presented to you. So on the right and left side, we have a drawing that is actually predominantly mentioning the various interesting manifestations. So these manifestations, say for example, polyuria and polydipsia, may be noticed in diabetes mellitus. If you talk about independent manifestations, polyuria, polydipsia, we say diabetes mellitus, exophthalmos, bilateral alopecia, and yes, comedones. So these manifestations, flat pads, these manifestations probably be also be related to hypothyroidism. But when we talk about Cushing's disease, we have one or two very promising and significant manifestations in addition to all these. The one is pendulous abdomen, thin skin, soft skin with predominant vasculature, and yes, calcinosis cutis is another interesting manifestation, hyperpigmentation, muscle wasting. Apart from these two or three, bilateral alopecia, polyphagia, and polydipsia. So if we come across any such kind of manifestations in a dog, which is middle-aged to an aged dog, so we can always suspect a Cushing's disease. So apart from dermatological manifestations, the Cushing's patient always also have respiratory manifestations like panting, pulmonary hypertension, and mineralization. So this is again related to hepatomegaly. There will be hepatomegaly in a Cushing's patient. So enlarged, enlarged liver, a big liver actually presses the diaphragm more cranially into thoracic cavity, and thereby giving a minimal space for the lungs to expand when they inhale. So this actually causes a patient to have more amount of panting, and there will be mineralized or mineral deposits in the trachea, bronchi, because of which it causes, or even sometimes in blood vessels. So because of that, it causes hypertension and sometimes mineralization of respiratory tree. And in very severe cases, whenever there are lesions, space of pen lesions or tumors or masses in the pituitary area, thereby it also causes some sort of nervous symptoms like seizures, circling symptoms, or head pressing, etc. So these are other kind of manifestations which are seen in advanced conditions and maybe not so commonly noticed with each and every patient suffering with Cushing's disease. Then how can we diagnose the Cushing's disease? The Cushing's disease, as we have seen, can be diagnosed most commonly and to majority of extent based upon the specific manifestations, but to say and to perform some specific tests, it can be diagnosed with these parameters. Like it will have a polycythemia and it will give us a stress leukogram, which is a common abnormal features of the blood picture. And when we look at the biochemical profile, there will be elevated liver enzymes, there will be elevated serum alkaline phosphatase, and there is also an elevated fat actually in the form of cholesterol. So these two are the hematobiochemical alterations which may not be specific for Cushing's disease, but we notice it in this disease. And subsequently, if you just move forward, we can also suspect or evaluate the urine for diagnostic protocol of Cushing's disease, where there is a decreased specific gravity of the urine. Again, it is an interesting finding that correlates with the diabetes mellitus. In case of diabetes mellitus, there is polyuria, polydipsia, but the specific gravity of the urine will be more. Whereas in case of Cushing's disease, the specific gravity is low. So this is one of the differentiating point for us to differentiate that specific manifestation from diabetes mellitus. And the radiographic abnormalities, yes, as I was talking to you, the radiographic abnormalities, there will be bronchial calcification. There will be bronchial calcification and adenocarcinomas, or adrenal adenocarcinomas can be seen, and hepatomegaly. So these are some of the interesting features of the specific X-ray findings that are expected in a Cushing's patient. Apart from all these things, as we were talking about calcinosis cutis, which is nothing but the deposits of the calcium minerals on the skin are within the skin layers. The same thing can also be experienced, can be examined, and can be identified on X-rays as radio opaque materials, mineral deposits in the skin. So where you can see the normal bronchial pattern of the lungs X-ray in a normal patient, patient that is suffering with a respiratory disease, and whereas here you can see mineralization. So there is a clear-cut difference. The mineral deposits here, the mineralization that is present in bronchi or various respiratory components, which are actually differentiating point for us to confirm Cushing's disease. So keeping those things aside, and we have certain laboratory other tests for us to confirm this Cushing's disease, that is adrenal function tests and ACTH stimulation test and low dose dexamethasone suppression test. So among these three tests, low dose dexamethasone suppression test is considered as a more specific and more sensitive test to confirm the Cushing's disease, where dexamethasone at a minimal dose is administered in the blood, will be collected at 0, 4, and 8 hours of interval, and will be evaluated for cortisol levels that is present in the blood. So the cortisol levels that are present at 8 hours will be considered and will be calculated to see and confirm that Cushing's disease. So this is one of the confirmatory tests to Cushing's disease, but it needs a good laboratory facilities to evaluate all these things. Coming to the treatment, most of the times when the Cushing disease is diagnosed, the treatment, the medical management, I can say, is just a palliative kind of treatment, because if the condition is a pituitary dependent kind of Cushing's disease, where there are tumors or masses neoplasia in the pituitary gland, probably medical management may not be so fruitful. And if it subsequently causes hyperplasia of the adrenal gland, or if there are any pathology of the adrenal gland, so we can go for adrenalectomy, but such dogs should be maintained on cortisol for throughout his life without causing again excess or low amount of cortisol. So practically it's not so easy to follow this, but as I told you, a palliative treatment is always there. So we have certain drugs like lysotren, which actually selectively cause the degeneration of adrenal cortical cells producing cortisol and leading to some extent, and thereby helping in the production of certain amount of cortisols. And we have some other medications like mitotane or trilostane, which can also be given, but all these drugs has got certain side effects, and they should be very critically monitored, and periodically the blood test and the cortisol levels should be estimated, and to see how it's been working, and so many other side effects because of these drugs. But as we have to do some treatment, and it's always a palliative, we have another drug which can be safely given relatively safely that can be given is ketoconazole if it is given at the rate of 10 to 15 mg per kg body weight in 2 divided doses twice a day. So this drug also will give very effective medication, the remedy for the patient that is suffering with Cushing's disease. And coming to the next component and the most important component of today's topic is the hypothyroidism in dogs. And this hypothyroidism in dogs is one of the most important and frequently encountered complaint in case of dogs. Probably all the practicing vets who are here or any academicians or the PG students or anybody who is actually attending the clinics, definitely they will be experienced these patients, hypothyroid patients, and this is so commonly noticed and very important endocrine dermatopathy in case of canine population. So hypothyroidism actually is also alarming in case of human beings, as we discussed in the beginning of the topic. Alopecia, the baldness actually, which is correlated to hypothyroidism, infertility in humans. So hypothyroidism has become an emerging kind of endocrine disorder in human population. And equally, this is the complaint is also the graph is actually peaking up in case of companion animals or in case of dogs. So the thyroid hormones actually stimulate the various organs, or the various systems, or the various parts of the body, and they involve in the enzymatic activities and also involve in the metabolism of the various components. So whenever there is deficiency of thyroid hormone, it affects the multiple organs and thereby it causes multiple manifestations, varied kind of manifestations associated with the multiple organs. So the disadvantage and I can say the unfortunate thing about the hypothyroidism is about its misdiagnosis, and this the most important reason for the misdiagnosis of hypothyroidism is non-specific signs, or I can say though we have some significant manifestations, but they are not specifically for hypothyroidism patients. They are actually can also be noticed with other diseased conditions. So this is the reason why the most of the times in a learning vet or in a learning practitioner, with a learning practitioner most of the times. So these hypothyroid patients, the hypothyroid cases, they go undiagnosed or misdiagnosed. So whenever there is hypothyroidism or whenever there is the deficiency of thyroid hormone, what is actually happening in the gland is there is the structural and functional abnormalities are taking place in the thyroid gland and thereby causing a deficit production of thyroid hormones and thereby causing the complaint hypothyroidism in dogs. So the thyroid gland actually that is present on either side of the trachea, which is actually a H-shaped gland just below the larynx that is present, and is regulated by hypothalamus, and it is also being regulated by the pituitary gland. So this the thyroid hormones that are released from the thyroid gland are influenced by hypothalamus and the pituitary. The hypothalamus secretes thyroid releasing hormone, and this thyroid releasing hormone ignites the pituitary gland to secrete thyroid stimulating hormone. When the thyroid stimulating hormone attacks the thyroid gland, it releases three hormones: thyroxine, T4, triiodothyronine, T3, and of course calcitonin. The follicular cells, they release T4 and T3, and the non-follicular cells, they release calcitonin. So these are the three different hormones that are produced by the thyroid gland, which are actually influenced by the hypothalamus and the pituitary gland. So T3 actually composes only about 30 to 40% that of the secretion from the thyroid gland. And the majority portion is the T4, which is called the levothyroxine, that is released and secreted from the thyroid gland. So these are the important hormones, that are released from the thyroid gland, which plays the major role in every day-to-day life, and it influences not just only one organ or the one system, but it influences multiple organ systems and multiple glands in the body. So this quickly, hypothyroidism can be a congenital hypothyroidism when there is a deficiency of iodine in utero, or it can be an acquired hypothyroidism when the thyroid gland undergoes a sort of disease or a degeneration or atrophy due to varied reasons. So that is called as an acquired hypothyroidism. This acquired hypothyroidism is again of two types, the primary and the secondary acquired hypothyroidisms. In primary acquired hypothyroidism, there is insufficient secretion of the thyroxine, whereas in secondary, there is inadequate TSH from the pituitary gland. So there is a difference between the primary hypothyroidism and the secondary hypothyroidism. In the primary hypothyroidism, the thyroxine is insufficiently secreted, and whereas in secondary, the TSH is actually insufficiently produced, and thereby it causes the hypothyroidism. So just remove this. Right. So to be very clear, I just want to talk the same components here. So we have a primary hypothyroidism and a secondary hypothyroidism. So in primary hypothyroidism, what happens is the thyroid gland is affected, and there is an atrophy, or there can be a degeneration, or we can say that primarily the thyroid gland is affected. So when the thyroid gland is affected, the thyroid hormone is not released. That is, the thyroid hormones are not secreted into the system. So this is what is called as primary hypothyroidism. Whereas in secondary hypothyroidism, it is caused by the disease of the pituitary gland. So when there is the disease of the pituitary gland has to release TSH. When the TSH is released sufficiently, it will go and help in the release of thyroid hormone from the thyroid gland. So when TSH is not effectively produced from the pituitary gland, the thyroid gland has not enough TSH to release the thyroid hormone. So there is TSH deficiency here. So thereby the thyroid hormone is not sufficiently released. So thereby causing hypothyroidism. So put this in again a different manner in another way. So in case of primary hypothyroidism, as we have seen, the thyroid gland is affected, so T4 is not released into circulation, but TSH is released from the pituitary gland. So TSH will be always releasing, and it is producing more amount of TSH going and stimulating the thyroid gland to release the hormone. But because there's a problem in the thyroid gland, thyroid hormones are not released, but TSH will be continuously secreting. So what happens in a blood picture? There is low levels of T4, but elevated levels of TSH is seen. So elevated TSH with low T4 is always a significant finding that we notice in hypothyroidism patients, which is actually a confirmatory diagnosis. Similarly, when there is a normal TSH, okay, so the TSH may be normal or maybe less, because this is problem with this is a secondary hypothyroidism where the pituitary is affected. So when the pituitary is affected, it depends upon the severity and the damage of the pituitary gland. So it may be releasing TSH, but not to the extent that is necessary for the secretion of the thyroid hormone. So if it is released in a little bit of amounts, the TSH, so we can notice a normal level of TSH or maybe a low level of TSH. So when there is a low level of TSH or normal TSH, but with T4, it is not the primary hypothyroidism. So it can be a secondary hypothyroidism. So this is how we can differentiate the hypothyroidism, whether it is a primary or secondary. So yes, this is again an important and interesting axis one should understand. The regulation of hypothalamus and pituitary on the thyroid hormones, on the thyroid axis, is influenced by or is regulated by thyroid hormones, that is T3 and T4. So when there is low levels of T3 or T4 in the blood circulation, it sends a feedback to the hypothalamus to release thyroid releasing hormone, and this thyroid releasing hormone stimulates the pituitary gland to secrete thyroid secretory hormone, TSH, thyroid secretory hormone. So this TSH stimulates the thyroid to secrete or to produce thyroid hormones, that is T3 and T4. So when these T3, T4 are maintained in optimal levels of the blood circulation, again a negative feedback is sent to the hypothalamus to stop the production of the TRH and then subsequently TSH, and then no further T3 and T4 are released. So T3 and the T4, the blood levels or the serum levels or the circulating levels of the T3 and T4 are the regulatory mechanisms for hypothalamus, pituitary, and thyroid axis. So the prevalence of hypothyroidism, as Dr. Nagaraj sir was saying, it is nowadays it has become so common and it is present in almost all ages of the dogs, though it is noticed in dogs which are adult and in geriatric cases. Among the certain breeds, though it is seen in almost all breeds, but there are certain breeds that are commonly noticed in Indian conditions like golden retriever, boxers, cocker spaniels, dobermans, etc., etc. But when it comes to the gender differentiation, almost both the gender of the dogs are equally affected, but relatively this condition is a little bit more in case of females, that too in case of intact females. We can notice a bit of higher prevalence. So in other words, hypothyroidism is seen in almost all dogs of all ages and common breeds that we come across in our day-to-day practice. What actually causes this hypothyroidism? Hypothyroidism, as we have seen, that can be a primary hypothyroidism, or that can be a secondary hypothyroidism, that can be a congenital hypothyroidism. These are the 3 or 4 common important types of hypothyroidism. But what exactly causes this primary hypothyroidism? This primary hypothyroidism is caused by an autoimmune kind of complaint. Mostly it is a lymphocyte thyroiditis, or it can be an idiopathic atrophy of the thyroid gland. So these 2 are the common causes for the occurrence of primary hypothyroidism. But among these 2, we can say lymphocytic thyroiditis is so common, which is ranging about 50 to 60% of hypothyroid cases. So there is a lymphocytic infiltration, and the macrophages that are present in the gland will distract or destroy the gland, the thyroid gland, and thereby interfere with the hormone production. And this is also being caused by some other conditions or the complaints called as associated with anti-thyroid drugs or thyroidectomy. So in these conditions also the parenchymal loss will be there, and it is replaced by the adipose tissue and the connective tissue fibers, thereby causing a low level production of T4 or the thyroid hormones. And we have a secondary hypothyroidism, which is caused by the pituitary diseases or the pituitary neoplasia or any tumors of the pituitary gland or hyperplasia of the pituitary gland, and thereby it reduces the thyroid function. So the primary one causes primary lesions within the thyroid gland, but the secondary hypothyroidism causes lesions within the pituitary gland. So this is how we can differentiate the primary and the secondary. And of course, we have the congenital kind of hypothyroidism, which is relatively very rare in case of companion animals. This is related to iodine deficiency, or it can be improper or the defective development of the gland, the thyroid gland, during the infant life. And interestingly, the literature nowadays also says that commercial foods actually which contains an excess amount of dietary thyroid also gradually, progressively induce a thyroid disorder, thereby causing hypothyroidism. So we should be very, very careful while advising the commercial foods to the pets, particularly if they contain iodine-rich kind of food. This is going to induce thyroid disorder in due course of time. So the clinical manifestations of the thyroid deficiency complaint or hypothyroidism, as we discussed, the thyroid hormones influence it regulates the functions or the metabolism of multiple organs, or it also causes abnormalities in different systems in the body. So the manifestations also are related to various organs, the manifestations of various organs. So, and as we discussed, the manifestations are many times are non-specific for. So we can classify those manifestations into two different kind of manifestations. The manifestations which are commonly noticed are manifestations associated with abnormalities of the metabolism or decreased metabolism. It can be a dermatological signs even, which are quite common. And we have certain uncommon manifestations which are associated with the nervous signs, so the cardiovascular system, ophthalmic and respiratory system, etc., etc. So let's see one by one. So yes, this, can you just imagine a Dachshund dog like this, a Dachshund dog. This is just a Dachshund dog, and this one is a Beagle. It's a Beagle and a Labrador. So this is one of the most important abnormal metabolism, the signs associated with abnormal metabolism in case of hypothyroid patient. So these dogs, the hypothyroid patients, they become obese, fatty, and they're just not obese or fatty, they're extremely obese and they're excessively fatty, and they become so round and they can't even move, walk, or they just become so lethargic. And what is important here is these dogs, they have either normal appetite or decreased appetite. So their food intake is either normal or there may be a decreased food intake, but still they become obese. So this is very much important and interesting find history that we should collect from the owners. If it is there, then we can suspect that it could be a hypothyroid person, I mean it could be a hypothyroid patient. So at this with this physical condition, with this appearance of the physical condition, obviously these dogs become lethargic. They don't show any interest towards the physical activity. There is completely exercise intolerance, and there is mental retardation, and they're extremely weak, and they just don't want to move or walk or run or jump or do their routine activities. So this is one interesting and important clinical manifestation that is related or associated with decreased metabolism. Then we have another, though it is something unusual, but we can also come across certain neurological signs, and these neurological signs are related to abnormality in neuromuscular transmissions. So this hormone, the thyroid hormones, are essential for the balance in the sodium potassium pump activity in the neurons. So whenever there is a deficiency in the thyroid hormone, whenever there is hypothyroidism, it causes an imbalance in the sodium potassium pump activity, and thereby it delays the transmission of signals through the neural axons, or it delays the transmission of signals in the neuromuscular ends, and thereby it causes a peripheral nerve dysfunction. And this peripheral nerve dysfunction initially it is exhibited in the form of exercise intolerance, as we have seen with decreased metabolism, muscle weakness, ataxia, but subsequently it also exhibits in the form of paralysis. It can be a complete paralysis, or it can be a tetraplegia, or it can also be, like you can see it here, a facial paralysis. Okay, so these are all certain neurological abnormalities that we can notice in case of patients suffering with hypothyroidism. And yes, the hypothyroidism did not even left the eye, so it even shows an abnormalities that actually causes ophthalmological disorders. But the interesting ophthalmological disorder in case of hypothyroid patients is an appearance of a white spot in the cornea. So this white spot, which is also called as corneal lipidosis, this is one of the important manifestations that we notice in hypothyroid patients. And this corneal lipidosis is due to the presence of high levels or increased levels of cholesterol or fat that is present in the blood circulation, and sometimes leads to have an ocular changes. So this is what is called as a corneal lipidosis. It may also cause corneal ulcerations. It may also cause uveitis and secondary glaucoma, and sometimes in very severe conditions, it is also going to cause keratoconjunctivitis, SICA, due to a dryness of eyes. So, among these, the most important manifestation of ocular ophthalmic disorder or ophthalmological complaint is corneal liptosis. So yes, this is another important common question from most of the clients. They'll be coming to your clinic, or they may be contacting you and asking you why my pet is not coming to heat every time, or why my pet is not in season, though he is 3 years or 4 years. So the answer is hypothyroidism. So thyroid abnormality, just like in humans, as we discussed in the beginning of the topic, I told you, and we discussed that it is causing infertility in case of humans. Yes, no doubt it is also going to cause certain abnormalities in the heat that can be a silent heat, or that can be a split heat, or that can be a prolonged heat, sometimes no heat at all. So these are all the certain abnormalities that we notice with the estrus of a patient or the dog that is suffering with hypothyroidism. So in case of males, this hypothyroidism complaint causes a low libido, and it may also cause testicular atrophy. So this in general, or I can say in nutshell, this hypothyroidism also causes abnormalities in the reproductive system, or the reproductive manifestations, both in the male and female, thereby causing abnormal heat and decreased libido. Just a second. Well, so the next system that it affects is the cardiovascular system. Well, the thyroid hormones has got a positive inotropic effect on the myocardium, and it also interferes. It is also important to, as we discussed with the nervous system, it also plays a role in the conduction transmission within the myocardial network. So whenever there is an imbalance of thyroid hormone, or whenever there is a deficiency of the thyroid hormone, its inotropic effect on the myocardium and the conduction abnormalities will result, and thereby it causes myocardial diseases in a chronic course of time. It causes dilated cardiomyopathy, or sometimes it also causes bradycardia or fibrillations or very other sorts of arrhythmias. So put together, it causes it adds up to some other metabolic disturbances like respiratory dyspnea. It causes cyanosis of tongue and the pale mucous membrane, etc., which are actually primarily related to the cardiovascular signs. So I mean to say that there is possibility of secondary dilated cardiomyopathy or cardiovascular abnormalities whenever the patient suffers with dilated cardiomyopathy, when the patient is suffering with hypothyroidism. Then coming to the dermatological manifestations. So the thyroid hormone actually it is very much important for the maintenance of the skin, its functions, and as we have seen, the thyroid hormones are important for the maintenance of 3 important functions. One is the folliculogenesis, next one is epidermopoiesis, and the pigmentation process. So whenever there is deficiency of thyroid hormone, these are the 3 components of the skin that are going to be affected, and thereby it causes the manifestations, the abnormal clinical signs. And we also discussed that the alopecia that is present in case of endocrine associated dermatopathies is non-inflammatory and non-pruritic kind of alopecia. Apart from that, it is also a bilateral alopecia. So this is a very specific and pathognomic manifestations for these hypothyroidism. So primarily the dermatological manifestations are the initial manifestations that start with whenever the patient suffers with hypothyroidism. But of course, the other signs or other manifestations associated with different other systems are also noticed, but they appear when T4 secretion is very much severely affected. So yeah, these are the various stages that are present in case of growth of hair. So this is the first stage, what is called as an anagen phase, where there is enough nutrition for the hair follicles to to survive, and this is also called as an active phase, or the growth phase. And after some time it reaches to the catagen phase, where the hair follicle detaches itself from the nutrition supply, and then gradually it reaches to the telogen phase, where it is the resting phase, where the nutrition of the blood supply is completely detached, and the hair fiber, or the follicle is ready to fall off, and the hair dies and it is ready to fall off. So thyroid hormone, this is very much important. Thyroid hormone actually initiates the anagen phase of the hair growth. So the thyroid hormone is important for the presence of the anagen phase. So whenever there is deficiency of the thyroid hormone, the anagen phase is not actively participated. It is not actively seen in the process of hair life cycle, we can say. But yeah, this is what I was just talking a few minutes ago, as this is a clear-cut difference between the hair follicle of a dog from that of a human being. The hair follicle in dog is a compound hair follicle. It has got a primary hair follicle, around which there are about 10 to 15 secondary hair follicles. So completely it is called as a compound hair follicle. And this compound hair follicle actually gives thick appearance of the fur on the dog's body with two different types of hair. One is a primary hair follicle, which is tough, rough and brittle, and hard, or tough, around which we have a soft hair, secondary hair follicles. So because of this, the hair fall in case of dogs is what we call as a cyclical process. It's not like in humans what we notice, which is a permanent kind of hair life cycle. When the hair follicle falls off, there is no point of the growth of the secondary hair in case of humans, but it is not like in case of dogs. So in dogs, the primary hair follicle will shed off frequently, and then the secondary hair follicles, one among them will come the next primary hair follicle, and then the cycle continues. And that is reason why even though dogs, they shed hair seasonally once or twice a year, they shed of complete hair, but they never appear as bald, as alopecia, unless there is any disease problem. So this is the advantage of a compound hair follicle that is present in case of dogs, unlike human beings. And this compound hair follicle, the presence of multiple hair follicles around the primary hair follicle, actually helps in a thermoregulatory mechanism. So whenever there is excess cold environment and the body wants to protect the heat, so they trap the air in between and then prevents the heat loss. And whenever there is they need to dissipate the heat and the air, so they just relax, and then the heat that is present in the body will be dissipated out. So this is the advantage of the compound hair follicle, not only just regulating the body temperature, but also helps in maintaining the cyclical process of hair fall mechanism. So what happens in case of hypothyroid patients is they actually reaches to telogenic phase, and I'll just take it out. Yeah. So in case of hypothyroid patients, when there is low amount of thyroid hormones, the hair follicle reaches and remains in the telogenic phase. As we have seen, it remains in the resting phase, and it inhibits the anogenic phase. So there is no active phase, but there is a rest phase, because of which there is loss of hair subsequently over a period of time, resulting in alopecia, and which is of non-inflammatory and what do you call it, non-chlorotic kind of type. So this alopecia is one of the important and the primary manifestation that we notice with hypothyroid patients, and this alopecia has got a specific points to note. So this alopecia is bilateral alopecia, symmetrical alopecia, which we notice on either sides equally and similarly in case of patients that are suffering with hypothyroid. And it starts with it also noticed at the neck region, in the dorsum of the neck region. It spreads throughout the body, just like Cushing's disease. Alopecia is noticed throughout the body, bilaterally, symmetrically, but it leaves the head and neck. So you usually do not notice alopecia in the head and neck, but except those two, it is present throughout the body. Another interesting feature I would like to reiterate here is, like, as we were discussing about the compound hair follicle with the primary hair follicle in the middle and having a secondary hair follicles around. So when there is in telogenic phase, the primary hair follicle will shed off and leaving the secondary hair follicles, which are soft, and they look like the hair of the puppy. So because the thyroid hormones, the deficiency of thyroid hormones inhibits the anagen phase, and it restricts the telogen phase, the secondary hair fibers or the hair follicles remains like that, and leaving the coat of the adult dogs, which is a soft kind of coat, leaving something like a puppy-like hair coat appearance, as we have seen here. So they are all adult dogs which are more than 10-12 years old, but their coat looks like they have a puppy kind of hair coat. And some of the dogs, they also exhibit loss of pigment on the coat. There is change in coat color. And this is again very striking and significant manifestation, the dermatological manifestation we notice, that is rat tail appearance. And there is bald thigh appearance. There is specifically loss of hair in the thigh region, giving a bald thigh appearance. Well, apart from the alopecia, what we are talking about is the hyperpigmentation, and this hyperpigmentation usually it is noticed at the alopecia areas, but at the same time it is also noticed in other portions of the body, like prevenal portions. And in very severe conditions, when there is a secondary bacterial infections or when there is secondary inflammatory conditions, the alopecia followed by hyperpigmentation and hyperkeratosis is also noticed, one of the significant manifestations of. This is how the pigmented skin will look like within the alopecia and also on the inguinal region. And also another interesting feature, the dermatological feature of hypothyroid dogs is there is failure to regrowth. That is called regrowth of hair follicles will be either delayed or maybe completely absent, which is also an interesting feature or important significant manifestation of hypothyroid patients. So apart from these manifestations, there is presence of seborrhea. So there can be either oily seborrhea or there can be either dry seborrhea. So it depends upon the severity of the complaint. So whenever there is deficiency of thyroid hormones, there is abnormality in the secretion of the sebum secretion of the sebaceous glands, and there's release into the hair follicles. So it may either cause oily seborrhea in initial stages, but in later stages, the skin looks dry seborrhea with dry flaky material that is noticed on alopecia areas, particularly on the tip of the ear or even the back, etc. So alopecia, hyperpigmentation, hyperkeratosis, seborrhea, dry seborrhea are striking manifestations of dermatological signs associated with hypothyroidism. And lastly, it also causes excess secretion of ceruminous glands that are present in the ear, and thereby causes ceruminous otitis, because excess secretion attracts the infection and thereby it causes otitis. So giving discharges and resulting in discharges in the ear, affected ear, and thereby causing otitis. Well, this is again another interesting feature of the dermatological manifestation we notice with hypothyroid patients. Actually, thyroid hormones are important for the catabolism of glycosaminoglycans. So whenever there is deficiency of the thyroid hormones, there is decreased catabolism of glycosaminoglycans in the skin, and thereby it causes accumulation of hyaluronic acid in the dermis, and this hyaluronic acid attracts the water, and it helps in the retention of water within the skin, and thereby causing mixed edema. So this mixed edema is noticed particularly on the face. It is noticed on around the eyes or in the temporal region, or it is noticed at the lips, and thereby it causes puffiness to the face and then mixed edemic appearance. And because of that, it also gives us a tragic face appearance without any expressions, with drooping eyelids among the patients that are suffering with hypothyroidism. So mixed edema along with the tragic face appearance is again an interesting features of dermatological origin associated with hypothyroid associated dermatology. So yes, in subsequent cases, as we discussed several times, and we repeatedly reiterated that the alopecia is a non-inflammatory and non-infectious and non-pruritic kind of manifestation we notice in endocrine associated dermatopathies, particularly in hypothyroidism. But subsequently, over a period of time, when this prolongs for a certain period of time, there is secondary infections, probably the bacterial or the fungal or the yeast or any other secondary ectoparasitic infections even, thereby causing secondary infections like pyoderma, bacterial pyoderma, or it may cause demodicosis or malasseziosis. So all these things subsequently will add up an additional manifestation to the alopecia, that is pruritus and inflammation. So when there is inflammation and then the pruritus to the alopecia lesions, the skin becomes hypertrophic. I mean, there is hyperkeratosis. So thickening of the skin, hyperkeratosis, hyperpigmentation, alopecia, bilateral symmetrical alopecia, particularly on the back, at the neck. These are all some of the specific significant manifestations apart from bacterial appearance. Well, so this actually hypothyroidism, because of these unusual and non-specific and non-significant manifestations, diagnosis is many times difficult for this complaint. But I can say the management of hypothyroidism is easy, but it is difficult to diagnose. It is difficult to diagnose because of the non-specific manifestation. But still, we can diagnose the case, or we can diagnose the hypothyroidism based upon the history and the clinical signs, how long the clinical manifestations are noticed, and what are the significant manifestations noticed, whether it is the metabolic abnormalities or the dermatological abnormalities. And these manifestations, coupled with the history and coupled with supporting laboratory findings, probably will help us to arrive at a diagnosis. So if you look at the laboratory manifestations, like any other endocrinopathy or endocrinopathy associated dermatosis, there will be non-regenerative normocytic normochronic anemia with elevated levels of liver enzymes, ALT, serum alkaline phosphatase, and increased levels of serum lipids, increased cholesterol, increased triglycerides. So these are some of the important hematobiochemical findings. But for the learners and also for who are actually involved in the practice and research here, the recent literature says that skin biopsy and histopathology will give us a confirmatory diagnosis for endocrine associated dermatopathies and also for hypothyroidism, where there is vascularizations and hypertrophy of the erector pili muscle, and there is almost very low amount of hair follicles in an anagen phase with thick dermis and epidermis. So these are the significant histopathological findings which helps us to confirm the diagnosis of hypothyroidism. And when there is secondary bacterial invasion and when there is secondary infections, there is a very degree of inflammatory signs are also noticed in histopathological findings. But over and above, as we have been studying about the diagnosis, we have a test therapy diagnosis, which is in which the hypothyroidism is the best example for that. It is, I mean, here the diagnosis depends upon the response to the thyroxine supplementation. So when the thyroxine supplementation helps the patient to, increase, I mean, alleviate the clinical manifestation. So that is a confirmation for hypothyroidism. So test therapy diagnosis is usually followed when we do not have these facilities to go ahead with in the laboratory. So apart from those things, what we have is to confirm the hypothyroidism. So estimation of thyroid profile is the ultimate means of confirmation diagnosis of hypothyroidism, where we'll be going to measure the T4 levels, T3 levels, and TSH. And we have various components of the thyroid hormones like these. And we have a thyroxine T4, we call it as a total T4, which is nothing but a sum of free T4 and T4 that is bound to the protein that is actually present in the blood. So free T4 here is actually the concentration of the thyroxine that is actually not conjugated to the plasma. Truly speaking, this free T4 is the hormone that is available for the tissues. So when we measure the free T4 concentration, this is only going to give us the concentration of the T4 that is available for the tissues. So probably it may not be going to give us the accurate condition of the thyroid gland to diagnose the hypothyroid condition. So it is better for us to go for total T4 estimation in order to confirm the thyroid, hypothyroidism in case of dogs. So hypothyroidism can be simply excluded if we come across any normal T4, but it cannot be always considered as hypothyroid if we come across any low levels of T4. So this is some sort of ambiguity that we have with T4 levels. But when we just move forward, T3 actually is not recommended. T3 alone, I mean to say, is not recommended for the confirmation of the diagnosis of hypothyroidism, because a portion, a limited portion of this T3 is produced and secreted from the thyroid gland, but majority of T3 that is produced is through deiodination procedure from T4. The T4 is converted to T3. So when there is enough amount of T4, the T3 is available. So T3 will give us ambiguity in the results. So we cannot usually depend on T3 alone for confirmation. So it is not recommended for diagnosis. What is again important here is the TSH. Actually, the basal levels of TSH will be elevated when the patient suffers with hypothyroidism. And when there is a thyroid profile showing excess, elevated, increased levels of TSH with low levels of T4, that is total T4, this is an important and interesting and confirmatory finding to say that the patient is suffering with hypothyroidism. So once the condition is diagnosed, as we discussed, the management or the treatment for hypothyroidism is very simple, and it can be managed with a single pill. So what is important here is the aim of treatment for hypothyroidism is to normalize the thyroid axis and to normalize the circulating levels of T4, and thereby, but equally, we should not cause any hyperthyroidism in the patient. So the management, for the management of the treatment, what we require is levothyroxine, that is T4 supplement, as we can see here in the one image that was seen in the initial stages of a discussion. So in primary hypothyroidism, there is deficiency of T4 with high levels of TSH. So when this picture is noticed in your blood evaluation report, so it confirms the primary hypothyroidism, and in those cases, supplementation of levothyroxine is the best and the only drug that is available, can be given safely, and it is to be given at the rate of 11 to 22 micrograms per kg body weight, either once or twice a day. But it should not be given with the food, because food interferes with the bioavailability of the drug, and that's the reason why it should be given preferably on the empty stomach for having complete bioavailability of the drug. And one thing what is very much important here is once the hypothyroidism is diagnosed in a patient, the treatment is lifelong. It should be continued for lifelong, but with periodical monitoring. So the monitoring should be done at least once in every 2 months, and the blood sample should be collected about 3 to 4 hours later in the treatment administration of the drug or the tablet, and to evaluate the levels of the T4, and then accordingly we can make the dose adjustments. So this is how we can manage, and it is very surprising for both the vet and also for the practitioner and also for the client to note the elevation of clinical signs. A single pill or a simple pill, which is a small size pill of levothyroxine, is going to affect on a wide variety of manifestations. Maybe it is the pigmentation, maybe it is the alopecia or obesity or exercise intolerance, whatnot. All the manifestations that involves multiple organs and multiple systems will be alleviated gradually and with a simple pill. That's the reason why I told you the management of hypothyroidism is very simple, but the diagnosis is a bit complicated and confused. So once you diagnose the complaint properly, and when you start giving levothyroxine at a proper dose, elevation of signs will be noticed probably maybe from 1 month, 4 to 6 weeks onwards. Initially, the manifestations, the elevation of signs starts with metabolic abnormalities, the metabolic signs, and then gradually it starts in showing improvement in dermatological manifestations, and by the end of 2 to 3 months, there will be complete elevation of the clinical signs, and the treatment should not be stopped at that point. The blood picture should be evaluated for thyroid profile, and it is always important to maintain the normal levels of thyroid in the blood circulation by adjusting the doses, and then the treatment be continued for lifelong. And once you discontinue the treatment, and then there is possibility of the recurrence of the manifestation. So treatment should be continued and will give definitely and absolutely positive results when the condition is properly diagnosed and the treatment is given with the appropriate dose and frequency. So to conclude, the endocrine dermatopathies as the common emerging complaints we notice in our daily practice, and they are actually many times will be challenging and very complicating. I mean, taking up a lot of time for the practitioner, also annoying for the dog and also for the owner. In my experience, have seen many owners, they are actually vexed with the recurring complaints, and they went up to going for euthanize their pets, but somehow the complaint was diagnosed and it was treated successfully, and they're having happily. So this is such an important thing, of which hypothyroidism is very commonly and regularly disease. It can be simply diagnosed based upon the clinical manifestation. If you have the necessity of going for, yes, you can go, and if you have nothing back. You can simply diagnose the case with test therapy diagnosis. That is, if you suspect hypothyroidism based upon the significant manifestations what we have discussed so far, you can simply start treating the patient with levothyroxine, and you can see the improvement within a month of period. And then if you notice there is elevation of signs, and then you can say that yes, this is hypothyroidism, I can just simply continue the treatment for its life. Thank you so much.
Thank you, Dr. Satish, for a marathon run into the entire canine endocrine dermatology. It was more like watching an English movie by the time span, but it was quite informative, quite good. We have a few questions, but just going into the questions, the prime question which any dermatology workshop, webinar will have is how do I differentiate Cushing from hypothyroidism and diabetes from clinical manifestations? So,
Yes. This was actually discussed particularly. I'll just repeat it again. Yes, we have, though we can say that the clinical manifestations are non-specific and non-significant to any of these dermatological complaints or endocrinopathy, endocrine dermatosis. But if you look at clearly, yes, there will be alopecia, there will be bilateral alopecia, there will be non-inflammatory, non-phoretic alopecia, there will be hyperpigmentation. Of course, in almost all endocrine-associated dermatitis. But in addition to this, if it is suffering with Cushing's disease, there will be abdomen, I mean pot-bellied abdomen, and there will be polyuria, polydipsia, which are actually not seen with hypothyroidism. And yes, these things and the distal abdomen with thin skin, which is actually not noticed in case of hypothyroidism. There is thickening of the skin hyperthyroidism. So this is how we can differentiate clinically based on the manifestation. And we can say that.
right, sir. The second question comes from hypothyroidism, sir. How is hypothyroidism in dogs and how is it different from cats? What is the difference between the two? Hypothyroidism in dogs and cats. This is a question from Malaysia.
Yeah, I don't think there is any difference between these two hypothyroidism, these two species. So,
Okay.
I don't think so.
Oh.
But
Normal.
you say, would you like to add anything to this because you are in dermatology?
Sir, you are mute currently if you want to speak.
Hello.
Yes, sir.
Yeah. Actually, hyperthyroidism is more common in cat. Hypothyroidism is more common in dog. So old age cats are having hyperthyroidism. So that may be the reason. In cat, Malaysia cats are more populated. So they may have the issue of hyperthyroidism. So hypothyroidism is rare in cat.
But when they suffer with hypothyroidism, they don't. There is no difference in the manifestations.
Yeah, same thing.
There won't be.
So the trichography also will be very much helpful. Trichogram. They see pace. See, telogen pace will be more like it is a simple thing in a practice. Apart from the clinical sign, we can also do that. It's very easy.
As soon as the question came in from Malaysia, Dr. Satish shifted to Dr. Nagaraj as usual. Dr. Nagaraj is a good goer to Malaysia and a good viewer there. So the next question is, sir, what is the normal TSH values in dogs, and how do we say abnormal? Normal TSH values in dogs.
It actually depends upon the geographical area. I cannot say exactly, but we have different values, but we cannot exactly rely upon them. It is always important to have an established normal values. We can't say exactly that. We can just define it one as a reference value.
Right. Apart from TSH levels, any other biochemical difference that we observe in a blood picture in a hypothyroidism in dogs?
Because thyroid hormone affects the metabolism of fats. There will be elevated fat. I mean, liquid picture will be elevated. There will be hyperlipidemia, hypercholesterolemia, hypertriglycerides, and there will be increased levels of ALT, serum alkaline phosphatase. So these are some of the non-specific, I can say, serum biochemical.
Right, sir. That brings us to the end of the session. We thank Dr. Satish for taking us on a long journey on canine endocrine dermatosis and giving us a full insight view. We thank Dr. Nagarajan, the entire executive committee of AVD, all members of INTAS, as well as all the audience for being there for a yet another nice session on canine dermatosis with special reference to endocrine diseases. Thank you, Dr. Satish. Thank you to all.
Thank you so much.
Thank you.
Thank you, Dr. Nagaraj sir. Once again, I thank you both for giving me this opportunity and specifically to speak on this ABD platform in collaboration with INTAS Knowledge. Thank you so much, Putin and Dr. Nagaraj sir.
Thank you. We are ending the session. Thank you.